Moving on to stroke, I had a lot of questions about what's utility and when would you do an intervention for stroke, like endovascular treatment versus TPA. Um, there have been recent trials looking at this. All three of them were presented at the International Stroke Conference in January, and then published in New England Journal of Medicine in February of this year. The first trial was the IMS3 trial. It looked at patients that had onset of stroke within 3 hours, and then gave all these patients TPA, and then some patients got endovascular interventional treatment, and other patients did not have that. And when they compared these two, they showed that although you had increased recanalization within the endovascular group, meaning the culprit artery was opened up at a much higher rate. The important thing that we're looking at is not recanalization, but obviously outcome. So the things that we would look at is, was there neurological disability any different? Was there any difference in mortality? Was there any difference in complications like intracerebral hemorrhage? And the interesting thing about this trial, unfortunately, along with the other trials as well, is that there was no difference in all three of these outcomes. So basically no benefit of endovascular treatment versus TPA. And this trial was actually terminated due to futility. They got to the number within that trial where they realized that there wouldn't be any statistical difference, so they had to terminate it. A second study was Italian synthesis expansion trial, expanding that window of onset of stroke to 4.5 hours versus 3 hours in the IMS3 trial. And this, they compared the TPA versus interventional treatment head-to-head. And when they looked at that, they also saw no difference in the three areas of outcome. The last trial was in North America, the MR Rescue trial, compared embolectomy or endovascular treatment versus standard care, and this expanded the window all the way out to 8 hours. So remember that standard care means that if the patient had onset within 4.5 hours, that they would get TPA, and then anything past that, the 4.5 to 8, they would get no intervention. And so those patients, the embolectomy arm of that trial would either get would all get embolectomy. So they compared those head to head. The other thing they looked at was the perfusion scans, where they do contrast angiography CTs, but then also added perfusion scanning to it. And the thought is that if you can see an area of the so-called ischemic penumbra, so an area around the occluded artery that is viable, then you would be able to select out which patients would benefit from endovascular treatment. When they looked at this trial, unfortunately, again, on all three of the outcome measures, neurological disability, intracerebral hemorrhage, mortality, there's no difference between embolectomy or standard care, TPA, or nothing. Also, even though the perfusion scan was able to show which patients would have improved outcome, it did not allow you to select patients that would benefit from embolectomy. So it was a double negative trial. So basically what this means is that currently the best thing that we have in terms of evidence-based, where the science is that patients need to go wherever they can get the earliest time to TPA. And if you spend more time getting them to a place where they would get interventional treatment or even perfusion scanning, and delay treatment to TPA, these patients will do worse. Now, this is all the caveat to say that this is an evolving thing. It's a controversial area of medicine, and just like with a lot of things, it very well could change, very soon, especially with newer devices, and as treatment continues to develop. But that's where we stand right now. And so I've gotten a lot of questions about this, and just want to make sure that you all have the most up-to-date evidence that's available.